Good afternoon, everybody. We apologize for starting a few minutes late, some technical hitches. My name is Sarah Lebu. I am a postdoc here at UNC, and I'll be moderating this session today. So just a quick run of show. We have 4 presenters today, and we are going to have each presenter have an allotted time of 15 minutes total. So that will be 12 minutes for their presentation and then about 3 minutes for Q&A. And I'll be moderating Q&A for each of the presenters and introducing them. So I'll let the first presenter go. And so I invite Crystal Estrada. Crystal is from the University of the Philippines, and she'll be our first presenter. Welcome, Crystal.
Hi everyone, good afternoon. I hope you can still see me behind the podium. So good afternoon, I'm Crystal Estrada. I'm from the University of the Philippines, Manila, and I'm here to present our study association between household wash facilities and menstrual hygiene management among Filipino women of reproductive age. So proper menstrual hygiene management, as defined by the WHO and UNICEF, entails the use of clean menstrual material to absorb blood, menstrual materials that can be changed in privacy as often as needed, and use of soap and water for washing the body is required, and access to safe and convenient disposal facilities for used menstrual materials. Poor menstrual hygiene management can negatively affect the health and well-being of girls and women and others who menstruate, and studies have linked poor or improper menstrual hygiene management with reproductive or urinary tract issues. It has also been found to impede learning and educational experiences, particularly for children and adolescent girls, as well as the productivity of working-age women. While menstrual hygiene management is crucial in spaces where women, adolescent girls, and others who menstruate can manage their menstruation safely and privately, most studies in the Philippines have focused on schools and in public facilities. So this overlooks the important role of household wash facilities in supporting menstrual hygiene management, despite previous research showing that women prefer managing their menstruation at home because of limitations in public facilities and access to menstrual hygiene materials. To the best of our knowledge, our study is also the first to explore the use of nationally representative data on exploring menstrual hygiene management in the Philippines, and the first to try and understand the association between MHM and household wash facilities. So our study aimed to address this gap by determining the association between household wash facilities and MHM among Filipino women aged 15 to 49 years old, using secondary data from the 2022 National Demographic and Health Survey of the Philippines. So household wash facilities in our study were classified according to the combined NDHS data on sanitation and hand washing facilities, while menstrual hygiene management was obtained from combined data for the ability to wash and change in privacy, and menstrual hygiene material used during the last period. So the 2022 Philippine NDHS data covered all 17 administrative regions of the Philippines. So I just showed here the Philippines. It's in Southeast Asia. Okay, so we have 17 administrative regions in the Philippines, and the Philippine NDHS 2022 version covered all 17. And it also included women of reproductive age, that's 15 to 49 years old. And it included data from women who reported their most recent menstrual period in the last year. To answer our question, we obtained the Philippine NDHS dataset, and we only retained the variables that were of interest in the study, so mainly on selected socio-demographic variables, WASH and MHM data. And then we also generated descriptive statistics and performed logistic regression using Genovia. So our study found that the median age of women was 29 years old, and about 6 in 10 lived in rural areas in the Philippines, and majority received at least secondary education and identified as Roman Catholic for their religion, and 46%, almost half, were in the two lowest wealth quintiles. So our study found that while majority had fully compliant household wash facilities, 22.16%, or about more than 5,000 households, still did not have fully compliant household wash facilities. And this reflects progress towards achieving our SDG 6 goals. However, it also implies that there is still a segment of our population, our Filipino women, who are in vulnerable situations in terms of their menstrual hygiene management. We also found that while majority had properly managed MHM, 4.36% had poorly managed MHM. So meaning still there are women and children and others who menstruate in the Philippines who do not have access to privacy and safely changing their menstrual hygiene materials or managing their menstruation. We also found that fully compliant household wash facilities, meaning those with at least basic hand washing and sanitation facilities, were significantly associated with their menstrual hygiene management. That is, women in households with fully compliant wash facilities were almost twice as likely to have better or proper menstrual hygiene management as compared to those for households with no compliant wash facilities. This association was confounded by select social demographic factors, particularly educational level, religion, and household wealth index. So in conclusion, our study found that Filipino women living in households with fully compliant wash facilities significantly enhanced their ability to manage menstrual hygiene. So with these findings, what do we do next? So the findings of our study highlight the importance of achieving at least basic hand washing and sanitation facilities for all households so that we can address women's specific wash needs, particularly for MHM. It also is important to highlight that there is a need to strengthen existing wash and MHM programs and policies in the Philippines, especially targeting the 22% which had non-compliant wash facilities. In addition to that, the findings of our study also may support the inclusion of MHM and wash, particularly menstrual health and wash in our Philippine laws, particularly on reproductive health, because the current law of the Philippines does not explicitly include menstrual health in the reproductive health law, even if we consider menstrual health as an important facet of reproductive health. Our study also can contribute to the evidence in ensuring that WASH and MHM health promotion and education activities are strengthened in the local context, particularly for the underserved and isolated areas where there is limited information and access to MHM. Our study also considers, we also can consider our study to support the call for developing more MHM and gender-sensitive WASH indicators. Okay, so MHM and gender-sensitive WASH indicators should also be considered for inclusion in local or national surveys to ensure that quality of MHM practices, such as the availability of menstrual waste disposal facilities, the frequency or the ability of women or adolescent girls or others who menstruate to change their menstrual materials as frequently as they want, and the accessibility of different kinds of menstrual materials is also monitored and evaluated, apart from evaluating and monitoring just the facilities for MHM. So with that, thank you very much. And if you have any questions or are interested to know more about our work, my email address is here. Thank you very much.
Thank you, Crystal. You could remain standing for a few questions if we have any. We welcome any questions.
I have so many questions. But I'm wondering if I wait till the end and
No.
make the private discussion.
We can take just one, maybe.
Yeah, I walked in late though, so I don't know. Sorry. Hi, thank you so much. I walked in late, so I apologize. Maybe I missed a few slides. But it looks like you're looking at households and like, what ages were you looking at? Sorry.
Oh, sorry.
Okay.
We were looking at women aged 15 to 49 years old. So
Okay.
reproductive age as defined in the NDHS data.
Okay. And I'm just curious because I've done a little bit of work with the Department of Education in the Philippines. When you were looking for policies and indicators, did you look across any of DepEd's policy work?
Great. I'm happy to know that you're also working with the Department of Education in the Philippines. Yes, we have the Wash in Schools program, that's WINS. They also have a component there for menstrual hygiene management. But we wanted to focus on looking at the household level as well, because most of the data and the studies in the Philippines are focused in schools and in public spaces. But it also is important for us to look at the household, because these are the spaces where our women and our children are frequently at. So we wanted to look at the household as well so that we can connect the work of the Department of Education and maybe the local government unit so that we can have a unified approach for menstrual hygiene management and wash in the Philippines.
Wonderful, thank you. I'm gonna pull you aside afterwards and we can talk.
Great, okay, thank you.
It's great work, I'm so excited to see.
Okay, thank you.
This is more a comment than a question and a little bit unrelated, but just, and we can chat afterwards as well. We did a 6-city study of public toilets and menstrual-friendly public toilets, and Manila was one of our cities, so it would be great to see if there's some alignment there.
I'm happy to hear that you're also one of the collaborators for the NDFE, because one of our colleagues in our department was the collaborator for that study. Professor Marian is our colleague in our department.
Amazing.
So yeah, we also looked at that. That's why we found that most of the work on MHM and WASH in the Philippines focused on schools and in public spaces, but not really looking at households. That's why we wanted to connect all the gaps and see all of these spaces and how we can improve WASH and MHM.
We can take one more.
Do you have any plans to be focusing on health facilities?
Oh, right, that's great. We haven't looked at health facilities yet, but perhaps it's something that we can consider moving forward. Thank you for that.
Yeah, well, thank you, Crystal. A round of applause for Crystal. Okay, and now we will pivot to a study in Ethiopia by Emily Cruz. Welcome, Emily.
Hi everyone, and hi again to a lot of these familiar faces. This is the menstruation room, so a lot of the people that are interested in this topic have been frequenting Windflower. So I'll be sharing some findings from the longitudinal assessment of SPLASH's menstrual health program. Today I'm going to be sharing specifically the findings related to the mothers and their engagement in menstrual health education. But let me first give a little overview of who I am. Emily Cruz, Director of Behavior Change at SPLASH International, and SPLASH is a clean water, water sanitation and hygiene, WINS, Wash in Schools organization. We work in many places now. Most recently, Tanzania, Zambia, and Malawi are our new expansion geographies. But the study that I'm going to be sharing findings from today is from our work in Ethiopia. So we've been in Addis Ababa and Bahir Dar in Ethiopia, and we also worked in Kolkata in West Bengal, India. So we believe that every child deserves access to clean water, clean hands, clean toilets, and menstrual health support. So that's a little bit about SPLASH. And as I mentioned, this study is going to be talking about our findings specifically from Addis Ababa. But our menstrual health program is part of a very large Wash in Schools program. So I wanted to kind of just give a quick overview. We do safe water, so safe, clean drinking water, hand hygiene, behavior change programming, operation and maintenance, so janitor trainings, but also utility level and systems level operation and maintenance, menstrual health work, and then sanitation. And related to menstrual health, we do girl-friendly sanitation. So we are either rehabbing or building completely new construction sanitation at every school that we work in. And we work at scale. So in every government school in Addis Ababa, I think it's well over 400 schools that we've reached in Addis Ababa. So a very big project. With new schools being added, we're still in conversation of what does sustainability look like for us as the population continues to grow. So Splash's vision for menstrual health specifically is to transform both the physical and social environment to empower girls to manage their menstruation with dignity. The physical is that girl-friendly sanitation, and the social is mothers, parents of all genders, teachers, male peers, younger peers, older peers, everyone, school administration, teachers. So the social ecosystem is what really is going to drive that normative change related to menstrual health, and we feel really passionately about that. As I mentioned, peer mentoring. So peer mentoring is a component of our program that we work on that creates a connection between young menstruators or pre-menstruators and an older peer so that they have emotional support at school. It's less about the anatomy, physiology, biology, management practices. That's delivered through our core curriculum, and more about social connection. And then our boy-facing puberty workshop is unpacking both menstrual health and the puberty experience for young boys. And this is to kind of promote empathy and allyship among these peers. And then our parent support group, which I'll be sharing some findings from today, increases knowledge, addresses misconceptions, misinformation, taboo, myths, so that parents have increased self-efficacy to initiate conversations with their young menstruators in their life. So how did we measure what we did? We did a baseline, so pre-intervention, a midline after one academic year, and an end line after another. So here you'll see those dates. We were in 10 schools in 4 subcities across Addis Ababa, and the schools were randomly selected. There were 200 girls, 100 boys, and 100 mothers in each group. And how did we analyze what we measured? We did response frequencies, so very basic, just count figures, but also generalized linear models to kind of understand how relevant factors interacted. So let's unpack how mothers are talking about MH with their children. So we found that mothers initiate conversations with their daughters, but not their sons. This is not a surprising finding. It's something that we'll see very frequently, even in developed contexts. 4 out of 5 mothers initiated conversations with their daughters, and only 2 out of 5 with their sons. And the children reported similar results. 9 out of 10 said that, yes, my mother has talked to me, and 2 out of 5 boys said, no, my mother did not talk to me, or 3 out of 5 boys said, no, my mother did not talk to me, and 2 out of 5 did. So the belief that mothers should talk about MH with their daughters before menarche, 1/5 of the girls talked with their mothers after menarche. So there is this kind of trend that we see of a girl gets her period, she comes to her mother, usually she thinks that she's very ill, needs to go to hospital, or that she's dying. We've heard that many, many times. Girls are very, very scared because they haven't heard about menstruation yet. Their mother will say, okay, you're not dying, don't worry, we don't need to go to the hospital, here's a pad, this is how you manage your period. And then the conversation doesn't continue, and it isn't repeated in subsequent months. Mothers are generally willing to discuss menstrual health and have positive views of menstrual health, but again, it's that confidence and knowing that, oh, I'm supposed to be continually doing this. I mean, we find that mothers want to be the support system for their daughters, but they just lack the understanding or confidence to continually reinitiate that conversation. And these results were consistent across the mid and end line surveys as well. So what affects mothers' comfort and desire to discuss menstrual health with their daughters? A lot of things. But what we found in our data, which again, not a perfect data set, not a perfect data collection tool, there's so much room for improvement, but what we did find was that mothers' comfort and desire to discuss menstrual health with their daughters increased if they knew menstruation-related facts, if they did not believe in menstruation-related myths, and if they had been educated about menstruation themselves in school. Mothers knowing about anatomy, changes during puberty or pregnancy showed no correlations between their comfort in initiating those conversations. All right. Mothers talking with their sons about menstruation. What affected their belief that they should discuss MH with their sons? And I'm going to click through this because it is the exact same variables that had an impact on their belief that they should discuss menstruation with their sons. So if they knew about MH, if they didn't believe in MH-related myths, and if they'd been educated about menstrual health in their adolescence. And again, anatomy, changes during puberty and pregnancy did not show any correlation with their willingness or desire to talk with their sons. Very similar to MH in daughters. So mothers' belief in myths about menstruation. Does improving mothers' knowledge decrease their belief in myths? And you would think that, yes, if they know more facts about it, there's going to be less room for a myth to kind of work its way in there. And mothers' belief in MH myths are only weakly correlated with their MH knowledge. So belief in MH myths is also strongly linked to social and cultural norms and past education, and modifying that belief will not modifying belief in MH myths will not occur with MH knowledge alone. It will likely require social behavior change. So we need a normative shift, and knowledge is not the pathway to that. So when people say, oh, we just need to have more MH education, even if girls are getting MH education, it doesn't mean that when they grow up and become mothers, that they're not going to believe in the negative myths that exist related to MH and that are very limiting to girls. Okay, so school attendance during menstruation. We found a big generational change, and I think that everyone who works in the MH space is familiar with this, that there's been a lot of positive progress when it comes to MH education. And with that, girls are missing school a lot less than their mothers did because they have access to better sanitation, better products, more information, and less stigma, but there's still a long way to go. So 5 out of 10 mothers regularly attended school during menstruation, while today, 9 out of 10 girls regularly attend school during menstruation. Discomfort in participating in class during menstruation is a lot less common today, with 5 out of 10 mothers and 2 out of 10 girls today. And school performance is less affected by menstruation today. So a lot of good news, but still a long way to go. Negative myths about menstruation have been reduced by interventions, so that's positive. Our money is being well spent. We're being good stewards. Girls began the program believing more MH myths than boys and mothers. During the program, it was found that girls had a huge reduction in those beliefs about negative myths. And then at the end, all groups were similar. So it was really interesting that girls had more negative beliefs or misconceptions than the other groups. And I think that this comes a lot from this fear of menstruation, this fear of menarche and experiencing, entering womanhood, and fear can really compound things and blow them up in your mind, and this was seen very clearly in the data, which was really interesting. Negative myths relating menstruation to marriage and cooking food still persist. Menarche also, in their heads, 22% of girls believe that menarche meant that they're ready for marriage, 14% for boys, so that's great, but that's a much lower percentage, and 35% for mothers, maybe because that was the case for them. And then no cooking during menstruation. The belief around that was highest among boys, so that seems like it's more of a male-dominated negative myth. Sorry, she just held up the 2-minute mark, and I was like, click. But I'm happy to take any questions. I feel like I probably should have moved through those a little bit quicker, but you in the green, happy to take your question.
Thank you. Hi, thank you for that. I actually have 2 questions, if that's okay. The first is probably really quick. The boy going through puberty workshop, is that taught separately from girls, or are they in the same room?
It's taught separately, and very intentionally so, because we found that the boys didn't want to ask questions related to their own puberty experience if their female peers were in the room. So it's led by a male focal teacher who's trained.
And are girls brought up to speed regarding puberty processes of boys as well?
They have less information about boys' puberty experience, and I think that that's definitely a gap in their curricula, and maybe it's something that could be integrated in the peer mentoring program. So yeah, there's definitely a mismatch between those.
And real quickly, the other ones,
No.
just maybe food for thought. Have you thought about the potential scalability of something like this? Would it be to work with the Ministry of Health, like in order to institutionalize it more so than just that intervention?
Yeah, that's a great question, and it's something that Splash is working really hard on. Our sustainability approach is, we have a multitude of avenues towards that. Curriculum integration is being the first, and we found a lot of success in Ethiopia where the Ministry of Education is agreeing to integrate our curricula. So I'm thinking that we'll have a lot of sustainability in Ethiopia in particular. And then in Zambia, Tanzania, and Malawi, our approach is a little bit different where we're engaging government at the front end as we contextualize the MH programming so they feel they own it. So then it will be a national level standard. So it's very much like, this isn't Splash's, this is your guys's. So that's kind of our approach there.
Thank you.
Hi, two questions. One, was there any work thinking about men or fathers' role in any of your intervention or your study? And then the second is, how did you tease out, you had a point that was puberty knowledge was not correlated to, I can't remember what the menstrual health knowledge specifically was, and I was wondering how you can tease out specifically like puberty and menstrual health since so much of that is interconnected.
Yeah, it definitely is. In terms of the engaging fathers, when we advertise our caregiver session or our parent session, which is what these study findings are from, it's meant for whatever caregiver is interested in attending, so fathers or mothers. We found that mothers are the main attendees, so that's why all of the respondents actually in this data set were mothers. Something that we've found is that fathers don't attend on that first day of school where school fees are being paid. It's really like the mother's role in Ethiopia in particular. So we are going to be doing an SBCC intervention that's targeting messaging towards fathers specifically. Fathers, community leaders, policymakers. So we recognize that that's a missed audience, and we're trying to find other avenues of engaging them. We also have for the curricula for the mothers, it's a tear-off sheet that they can take home that's meant for the father to read through, and it's just like the high level, really quick to digest key elements of the program.
Did you ask boys though if their father had talked to them? I'm just wondering because sometimes that's also very...
I would have to take a look at the data set. It's not quite fresh in my mind enough, so I apologize.
Let's take one more at the back, if you can answer that in under a minute.
I'll do it quick.
Thanks for the great presentation. Did you also talk to girls who are out of school?
We did not. So Splash's model is we work in urban schools that are the government-led public schools. So that's our intervention space. It's definitely something that I think we would need to partner with a community entity, community health volunteers, a different kind of deliverer of the program. It's something that Splash wouldn't have the mandate to do, but that we would want to support in partnership with another organization who works with out-of-school youth.
Thank you, Emory. So, welcome our third presenter, Allison.
Hi, my name is Allison Salinger. I'm from Emory University, and I will be talking about the effect of participatory design on women's sanitation-related empowerment in Fiji. So poor sanitation conditions perpetuate gender inequity by contributing to women's risk of violence and by compromising women's mental and physical health and well-being. This is in part because women are often responsible for wash-related household needs. Historically, WASH programs have used an instrumentalist approach, whereby the intervention leverages women's participation in order to improve WASH conditions. More recently, we're seeing a movement toward this framing of WASH programming as an entry point for improving gender equity outcomes. One way to do this is by addressing women's practical needs, for example, designing female-friendly toilets. Another way to do this is by addressing women's strategic needs, for example, involving women in leadership or decision-making roles within the program. RISE is a randomized control trial in 24 urban informal settlements in Fiji and Indonesia that is testing the impact of a water-sensitive infrastructure upgrading program. While women's empowerment is not an explicit goal of RISE, the program does address women's strategic needs by using a participatory design approach. That approach aims to involve all residents, but particularly those in marginalized communities like women or people living with disabilities, in co-designing settlement-level water and sanitation infrastructure. Some of the key participatory design activities in RISE are the establishment of community engagement committees, which have equal numbers of men and women representatives who serve as liaisons between RISE and the community. Participatory design workshops that included breakout groups for men, women, and youth, and household level consultations and observations to better understand the specific needs of women, children, elderly in the household. So we hypothesized that these participatory design activities would increase women's empowerment. Empowerment is defined as the expansion in people's ability to make strategic life choices in a context where this ability was previously denied to them. In order to measure empowerment, we used the ARISE scales, which are 16 quantitative scales representing 16 subdomains of women's specifically sanitation-related empowerment. These scales were developed and validated in 8 cities in 5 low and middle income countries. So a secondary goal of our work then is to revalidate these scales in a new study setting. They had never before been used in Fiji. From the 16 ARISE scales, we prioritize scales for inclusion in our survey based on their relevance to the Fijian context and the feasibility of those domains or subdomains having been affected by these participatory design activities I was talking about. So we included decision-making and menstruation-related decision-making, which is a subscale of the decision-making scale. And these are defined in the ARISE user guide as women influence and make decisions about sanitation inside and outside the home. We also included leadership, or women assume leadership positions, effectively participate and support women's leadership in both informal and formal sanitation initiatives and organizations. Collective action, women gain solidarity and take action collectively on sanitation-related issues. And finally, relations and menstruation-related relations, which refers to the interactions, including conflicts, support, hostility, and communication with key actors that shape women's sanitation-related experiences. So we administered these 6 ARISE scales to 281 women in 6 Tranche 1 or intervention settlements and 6 Tranche 2 or control settlements. That represents all 12 settlements that are participating in RISE in Suva, Fiji. For all items on all 16 of the ARISE scales, they have Likert type response scales from strongly disagree to strongly agree, and all scales are scored using an unweighted mean for all relevant items, such that the scale score winds up being 1 to 4, with higher scores representing more empowerment. Importantly, this is the first time the ARISE scales have ever been used to measure intervention impact. I'll talk about that throughout the presentation, but one thing to keep in mind here is that the intervention we're referring to is that co-design phase of RISE, so those participatory design activities. It does not include the build phase of RISE, so we can't assess the impacts of infrastructure upgrading yet, because that was not complete at the time of the survey administration. So here, each of the magenta bubbles you're looking at represents one of the 6 ARISE scales that we included on the survey. The blue text represents the factors that make up that scale. So just to take an example, that first bubble is decision making. That decision-making scale is made up of 5 factors. That first factor is made up of 3 items or questions, DM 01 to 03, and those 3 questions all have something to do with the respondent's ability to speak up in community-level sanitation decision-making. This factor structure is set out by the ARISE user guide, so we conducted a confirmatory factor analysis that showed us that our data from Fiji did fit this factor structure well, which just means that we are in fact measuring what we think we're measuring with these scales. So this graph shows the cluster or settlement, in this case level means, for each of the 6 ARISE scale scores. The blue bar is for tranche 1, or those 6 intervention settlements, and the yellow bar is for tranche 2, or those 6 control settlements. So we see that average scores for intervention sites are slightly higher than average scores for control sites for most of the 6 subdomains. To test intervention effect, we used walled tests of significance. So the striped bar is new here, and that is showing the adjusted mean difference between intervention and control sites. That mean difference is adjusted for average settlement level wealth score at baseline. So we see that women in tranche 1 sites were significantly more empowered than women in tranche 2 sites in terms of their decision-making and menstruation-related decision-making empowerment. All other subdomains showed no significant difference between tranche 1 and tranche 2. So here we're taking a little bit of a closer look at the decision-making scale alone. So each pair of bars here represents the proportion of respondents in tranche 1 or intervention and tranche 2 or control who answered strongly agree in red, disagree, or strongly disagree in red, disagree in orange, agree in yellow, or strongly agree in green, with more agreement representing more empowerment on that given item. So for example, the first 2 bars there represent responses in tranche 1 and tranche 2 to just that one item, DM01, on the factor 1 grouping of items on the decision-making scale. So we can see that the 2 factors that are really driving the difference in decision-making scores between tranche 1 and tranche 2 are factor 2, ability to influence community-level sanitation decision-making, and factor 4, ability to make major household-level sanitation decisions. And I might be biased, but I think this is really exciting because it means that women in intervention settlements are more empowered in terms of their decision making, not only at the household level, but also at the community level, and particularly at these higher levels of involvement in decision making. So not just these small household level decisions in factor 5, but major household level decision makings in decisions in factor 4. And then factor 2 represents women influencing the outcome of these decisions rather than sort of speaking up or participating at a sort of lower level of involvement in decisions. This held true for the menstruation-related decision-making scale as well, where we see that the 3rd item on this 1-factor scale, the item about having the final say, is really driving that difference between tranche 1 and tranche 2. So what does this all mean? The ARISE scales held form and function in a new study setting, not only in Fiji, but also the scales had never been used explicitly in urban informal settlements before, and were sufficiently sensitive to capture intervention impact. So ARISE, that means, can be used not only to understand how women's empowerment predicts or mediates WASH program objectives or health outcomes from WASH programs, but also to evaluate the impact of WASH programming on women's empowerment. Of note, both of these pathways are really understudied. So the ARISE scales provide a ready-to-use, easy-to-implement instrument that can be used to measure either one of these pathways. In RISE, participatory design activities increased women's sanitation and menstruation-related decision-making, again, both at the household and community levels, and particularly at those higher levels of involvement. This is important because it's exactly these types of high impact, high expenditure decisions that we see in the literature women are systematically excluded from. And if you can walk away from this presentation with only one thing, let it be this, that any WASH program, including one like RISE that did not set out to do so, has the potential to influence, for better or for worse, gender equity and empowerment or disempowerment, right? Participatory design and other inclusive approaches can help implementers be intentional about how they do that so that we can have positive impacts on gender equity outcomes, and the alternative may be inadvertently perpetuating harmful gender norms. So I'll just close by providing, this is output from other work, other research in RISE. This is a full toolkit that includes both a booklet and a card deck for implementers to sit with and use as they are designing programs. These are the participatory design activities that we did as part of RISE that led to that effect that we saw today. And references and some folks I'd like to thank.
Thank you. Any questions for the presenter?
Thanks, Allison. Do you know either from this work or any of the prior skill development work, do the factors that are water-related sanitation or water-related decision-making, sanitation-related decision-making, do you see an impact on non-WASH decision-making or household financial decision-making unrelated to WASH at all?
Yeah, that's a good question. So all 16 of the ARISE skills are sanitation related specifically. They're based on a systematic review and meta-synthesis that used WASH research to identify what those 16 subdomains of empowerment in sanitation are. So I think that while it was a really interesting question to look at how does sanitation related empowerment lead to potentially other forms of empowerment. But I think we'd have to have those other sectoral empowerment tools in order to make that assessment. And I don't know. Yeah, I don't know if we do. Yeah.
Any other questions for Allison?
Thanks, Allison. So you said that you did this partially through, or are you going to do it again? When you guys finish whatever you're doing?
Yeah, great question. I'd love to know the answer to that as well. Yeah, ideally, this gets repeated once the infrastructure systems in Fiji are all online and operating well. And ideally this gets repeated in Indonesia to see how the tools operate there and whether we see similar impacts. Stay tuned to find out.
Because maybe there would be an opportunity to do what was mentioned. I'm sure somebody somewhere has a women's empowerment tool that you could line up with your sanitation empowerment tool and
yes.
write a paper about it.
Yeah. Oh, interesting. Thanks, Kelly.
You can take one more. I think I might have one.
Oh, sure.
Could you talk a little bit about any limitations to your skill development process that might impact your results?
Yeah, so to clarify, we didn't develop the skills, we just were confirming their revalidation in Fiji. I guess one yeah, I'll talk about a strength and a limitation. So one strength, I think, is that RISE has a full-time in-country data collection or assessment team that has been with the project from the beginning of these participatory design activities until now. And so those folks helped us make tweaks and adaptations to the questions, never dropping a question or adding a new one, but because we wanted to stay true to revalidate the original scales, but just making sure that they made sense in terms of terminology, etc., in the context. And I think that was really helpful and necessary for anyone who's interested in using these tools in their projects. One limitation, I suppose, or thing that I like a call to action for the room, I guess, is that all the RISE skills have been validated only amongst adult women. And so what we weren't able to do was look at how men may have also been empowered through these processes, and whether women had particular advantages above and beyond men's benefits of the participatory design activities. So call to action, it would be really interesting to use these tools among a population of adult men and go through that validation process there to see, to doing that groundwork so that other folks can then run with these tools in male populations as well.
Well answered. Thank you. So last but certainly not least, Dr. Sheela Sinharoy.
Okay, great. Hi everyone, I'm Sheela Sinharoy from Emory. I will be presenting on women's and men's time use in rural Kenya, a cross-sectional study. This is work that was done in partnership between Emory and World Vision. And I want to make sure to acknowledge all of my co-authors who are listed here, as well as many others who contributed to this work. So, let me start the timer. Okay. So we know that the time women spend collecting water each day is substantial. This is measured as part of SDG 6, clean water and sanitation. It's also measured as part of SDG 5, gender equality, in which there's an indicator, indicator 5.4.1 relates to women's unpaid work, care work, and domestic work. So women's time spent on unpaid work is measured as part of both of those SDGs, and we know that water collection is a substantial chunk of that time in many parts of the world. So logically then, we can think about how provision of water has the potential to decrease women's unpaid work, and how then that would lead to, if we were able to reduce women's unpaid work burden, that could free up time for them to engage in other activities, including income generating activities. So this forms sort of a theory of change that we and World Vision were interested in exploring, whether if we were able to provide water, if that would actually decrease women's unpaid work burden, and whether that in turn would allow or facilitate women's participation and engagement in economic or income generating activities. So to kind of explore this idea, we had two goals to our study. The first was to begin just by measuring and comparing women's and men's time use in a rural area of Kenya. And then the second was to compare time use between women only in communities with and without an improved water source, focusing on the time that they spent on water collection and on income generating activities. So as I said, this study was done in rural Kenya as part of a partnership with World Vision. This was done in July and August of 2024, which is the rainy season. And so that is important. We'll come back to that in a minute. But the data collection took place in 6 communities where World Vision was implementing their Strong Women, Strong World Beyond Access programming. And so those 6 communities were purposively selected by the World Vision teams. And 2 of the 6 had already received an improved water source through that World Vision programming. The other 4 communities were slated to receive improved water sources later in 2024 or in 2025. And so in those 6 communities, in each of those 6 communities, 8 women and 8 men were recruited through a combination of purposive and convenience sampling. The teams aimed to recruit household dyads, meaning married couples, where possible. That wasn't always possible. So if they recruited a single woman, then they would recruit and enroll a man from another household in the same community. And the women and men, the teams administered surveys to the women and men that included questions on demographic characteristics and their time use over the previous day, so a 24-hour period. And then the descriptions of time use during that 24-hour period were categorized. We had 27 categories that we kind of pulled and adapted from other surveys like the Women's Empowerment in Agriculture Index. So, so this table is showing just some basic demographic characteristics of the study population. So you see in the first column, we had 95 participants, 48 women and 47 men. You see their mean age, that most of them were married. Again, some of the women were single, so that's why we weren't able to get household dyads in all cases. The vast majority had completed primary schooling or less. And a somewhat surprisingly small percentage reported having an improved source as their primary drinking water source. Remembering that 2 of the 6 communities had received an improved water source, but again, that this was the rainy season, and we know that people in these communities are more likely to collect water from unimproved sources during the rainy season. So things like surface water are more common in this season. Okay, so I have a couple figures. There's a lot going on in these figures, so I'm just gonna orient you to how they're set up, and then we'll walk through them together. So on the x-axis, we have the activities. So the first activity that we're looking at is water collection. And the y-axis is the average hours spent on that activity. And then for each activity, there's 2 bars. The pink is women, the blue is men. The number below the bar is the number of people who reported doing that activity. So in this case, for water collection, we had 33 women and 2 men who collected water in the previous day by their own self-report. And of those 33 women, they spent on average an hour and a half collecting water. The 2 men spent on average almost 3 hours collecting water, but again, that's two men out of 47. And there was no statistically significant difference in the average time spent on water collection between women and men. The next set of bars shows labor, unpaid labor and paid labor. And so we see that everybody in our sample, all 48 women and all 47 men, report doing some form of unpaid labor. Remembering that we had 27 categories, these are now collapsed into smaller buckets. So this unpaid labor captures any type of domestic labor, cooking, cleaning, laundry, dishwashing, caring for children or other household members. It also captures unpaid productive labor to produce something for the household's own use. So agriculture, for example, falls into this category. So we did see that men spent significantly more time on that type of unpaid labor, while women spent significantly more time on domestic labor and on unpaid labor overall. So women are spending more time on unpaid labor overall. No difference in paid labor. Fewer people reported participating in paid labor, and there was no difference in the time spent. And then these last set of categories, we have self-care, social activities, travel, and other. So self-care, again, captures several activities, and everybody participates in this because this is things like eating, personal hygiene, sleeping, reading, any sort of listening to the radio, things like that. this statistically significant difference where men spend more time on self-care is driven entirely by sleep. Not surprisingly. No difference in the other category, sleep. The difference is driven entirely by men spending more time sleeping. No difference in the other activities, social activities, that's any sort of community meeting or gathering, travel, could be commuting to and from a job or any other travel, and other is kind of a catch-all category. No difference between men and women in those. And then, so for our second goal of the study, we were comparing women only. So now we're dropping the men, we're focusing only on women in communities with and without improved water sources. So the figure is set up the same way. The first activity is water collection, and so we see that women in both types of communities with improved and unimproved water sources are still collecting water. We have 19 women in communities with improved water sources and 14 women in communities with unimproved water sources who are still collecting water. No significant difference in the amount of time that they're spending collecting water, regardless of the type of water source. Unpaid labor and paid labor, there is maybe a slight trend where the blue bars are the communities with improved water sources. So maybe a slight trend where women in those communities are more active in paid labor, but not statistically significant. And then no difference in the other types of activities and the amount of time that women are spending, regardless of what type of water source they have. So, to conclude, in our sample, recognizing this is a small sample, it's not representative, and we're talking about a data collection that was done during one season, so results could be different in a different season. In our sample, we found that women were spending significantly more time than men on unpaid labor and significantly less time than men sleeping. Among women in communities with and without an improved water source, we observed no significant differences in time spent on water collection or in unpaid or paid labor. So this was sort of surprising because we did expect, according to the theory of change that I showed earlier, that having the improved water source would reduce women's time burden for water collection and that it would potentially lead to their engagement in paid labor or income generating activities, and we did not find that to be the case in this sample. So what can we interpret from that? Potentially, something that we already know well from sanitation, which is that infrastructure alone does not necessarily change behavior. So adding an improved water source may not be sufficient to alter women's work burden or their time allocation. And of course, more research is warranted with larger sample sizes in different seasons and in other settings. We actually did this same study also in Honduras with World Vision again, and so we will have the data from that as well. And with that, I just want to thank our collaborators at World Vision US, World Vision Kenya, and St. Paul's University in Kenya, and of course all of the women and men who participated in the research. And happy to take questions.
Hi, thank you. I was just curious if you collected data like, where was the improved water source relative to people's homes compared to where would the unemployment source have been?
Yeah, great question.
Or
Yes.
other factors like that?
Yes, we did collect those data. I don't think that anyone is presenting those here at the conference, but that is a separate paper that is kind of underway where we have mapped the distances between, yes, households and the water sources. It's a great question.
On that, I guess the distance is a great idea, but also just like other factors that might be in the way. Like when we do a safety audits, we think about what are, trip hazards or snake infested areas or whatever, so I don't know if you guys have that data. But my actual question was, within the activity categories, was there anything about breastfeeding? And the reason I'm asking that is just because World Vision used to be really big, and maybe they still are, on like wash and nutrition. And so I'm just wondering if that made it into this study.
As a nutrition person, not a wash person, I wish I had thought of that and included that as a category. No, we have sort of
Unpaid labor.
yes, yes. Should have consulted with you, Kelly, in designing the study. No, we did not include a category for breastfeeding. But yes, to your first question, we also have, so the research activity was water journeys where people, data collectors went along with women on to their journey to collect water. And so there's all sorts of data about the whole journey, the terrain, any encounter, challenges, barriers, whatever that they encounter along the way. It's quite detailed and interesting, and there will be a paper coming out about that. Yeah.
Thank you for your presentation. It was very triggering as a woman. But I was wondering, when you looked at, since they didn't increase income generating activities, I was wondering if you quantified the number of activities, unpaid work that women did, and could you see that, like, well, instead of they're not working, but they're just taking on more, like, things within the home? So did you quantify that for a woman, or?
Yeah, exactly. Yes, we do have that data. We haven't calculated that, but we definitely could. That's a great point. That yes, essentially, my hunch would be that women are simply shifting their time from one type of domestic work to another. So probably, maybe if they're spending less time on water collection, which maybe they're not, we've discussed this, of course, a lot within the team, and speculated that maybe they're not spending less time collecting water, maybe they're just making more trips and collecting more water, so the time ends up being the same because they actually need more water. They weren't collecting it, they didn't have enough before, and now maybe they can get more water, but it's still the same amount, or they're doing some other type of domestic or care work.
Hi, the presentation was great. I was just wondering, did you find any sort of data on the different type of barriers, and can you talk more about it on the journey from home to the water collection point and back? Like the physical barriers and the mental barriers that they face?
We do. I just spotted Bethany. We're like hiding in that corner there. Bethany is the PI of this study and knows more about that component, the water journey component. So I don't know, Bethany, if you want to talk about that, or if it's something that you want to.
Yeah, we can talk after, so in case there's more questions on the timing stuff. But yeah, there's lots of.
Anybody else?
I also heard there's going to be a movie or a video
The journey?
of the journey.
Oh.
Do you not know about that? Oh. Okay, well, so the vision.
World Vision.
World Vision, yeah, but
Their
that's so
marketing team.
cool. You know, visual learning.
Yeah. Fascinating. Thank you.
Thank you.
We do have 10 minutes left before the close of the session, so I can open it up to questions to any of the 4 presenters. We still have Crystal, Emily, Allison, and Sheela in the room. Any additional questions to any of them? Going once. Then I think we can wrap it up. So we do have our poster session at the atrium, so I invite you to go check out the posters, and happy hour. Thank you. Yes, absolutely.
It's really fun. I enjoy listening. Thank you for doing it. Yeah, I love the presenters. Yeah. I was like so in it the whole time, which is rare for me nowadays.
And all kept time?
Yeah.
Yeah.
It was beautiful.
Yeah, are you you're at UNC?
Yes, I'm at the Water Institute. I work in one of the labs there.
I was formerly, well, I'm still affiliated, but I was a PhD student at the institute. I graduated in the spring, so now I'm working with Dr. Manga.
I haven't heard of them.
Kind of related.
What kind of work do you do?
I do sanitation infrastructure and looking at how extreme weather events may impact them. I do a bunch of household survey methods. I do a little bit of environmental sampling, but I feel like my most exciting piece is I work with dressing dyes, so injecting fluorescent dyes into sanitation facilities before it rains, and then I sort of like collect dye samples to observe the pattern of dispersal, and then attribute that to functionality of the system.
Yeah. Do you ever get to fake like natural disasters to see like how that would impact sanitation?
I wish I knew how.
It's like shape the building a little bit. I don't know.
I wish I knew how to. Yeah.
That's really cool though.
Yeah, what are you working on?
I'm with Tiffany, or like I was last year.
With the lead?
Yes. I work a lot. We're trying to see if we can use XRF, which is X-ray fluorescence, to see if we can measure like the surface level of pipes. Like if there's like any lead in the surface. Yeah. Like 'cause if there's lead on the surface, there's probably some on the inside. So like when the water infrastructure gets used, lead goes into the water. So we're seeing if XRF, which is like a portable lead, like can be used out in the field to like accurately scan lead.
Is it in existence?
Yes.
Oh my gosh.
So we like, or like our supervisor did a lot of the work, like a lot of the scanning over the weekend and stuff. We'd like drilled or like sawed like all the different water components apart.
Yeah.
And it was just like seeing if there was like any variation there.
Yeah.
And there was, like we found that like on a brass tap, for example, like depending on where you measure, there's like different levels, concentrations of lead.
Some positive hits.
Yeah. And a lot of them were like over 0.25%, which is like
Was that like the drinking water system?
It's hard. This was in Ghana, Uganda.
This was Ghana and Uganda. I know someone has been learning like Ghana and Uganda.
Yeah, I think that's
Surprising, but
no. So hopefully, like someday, like the supply chain and stuff can get like reinvented.
Yeah.
Use like steel and not galvanized like brass.
Who's like the largest manufacturer, do you know, of like the brass parts? I don't know.
I don't we use like India Mark.
See,
I think
okay. Yeah.
There's another one. Africa.
Yeah.
But yeah.
I come from Kenya, but my dad comes from Uganda, so I have family. I hear that, I was like, oh no. Okay,
So like I'm not sure like how widespread it is the whole country, but like the fact that it is still an issue, that's
And are you doing that in a city in Kampala? In Uganda?
I think Kampala, yeah.
Because I would imagine Kampala has like the best supply chain in the country. So if it's happening in Kampala, then it's likely to be happening across the country elsewhere.
You know, from the labels on the pipes, it's like Kampala, so it's probably really spread out there.
Yeah.
So yeah, I feel like a lot more could be done there. We're just like scratching the surface.
Yeah. And the government's on board and they're listening. Are you having conversations?
Yes. Last year they were doing, or the Water Institute was doing a state project with Ghana and Uganda. As far as I know, they put a pause with Ghana because of the change in government. But yeah, the government's like actually participating in the Water Institute. It's a collaboration. And like, what Timothy did to he brought the XRF with him to like demonstrate its capabilities. Yeah. So hopefully like they can like implement some wider changes.
I hope so, yeah. I feel like the Kampala City Council, KCCA is like super progressive. Yeah, and there's like a lot of them represented at the conference.
That's great. Hopefully. So maybe that's what like the collaboration started in the first place. They wanted to change.
Nice to meet you.
It was so nice meeting you also.
Thank you so much.
Sheela, we're going to the airport. We're heading back to Atlanta right now. She just got here this morning, and I got here Sunday, but yeah. I'm going back to do cocoa design workshop, which I was like, well, the fact that we have Cross-Sectional, I mean, there's like food security team and the environment team work with farmers, cocoa farmers. But this time they're like, hey, Kelly, come join. Yeah. If you're asking me to come, or I've never known my kids one with like they're here normally 4 times. We all go. We all started on it. We all on 5 or 7 days. And never separated. And so I don't know if this is the new norm, but they're doing 2 days a year with HB staff, and then some people are going over and like I guess hearing our ideas and going around and giving us something. So I don't know if this is the new norm or if they're just trying it out. But we have no money to see.
Maybe not research network.
I'm not here to I've never been to one, so I'm not here working. I had an intern who wanted to go overseas to work, and they'd never been anywhere, ever. They never left the US. And they wanted to go to Uganda. And I was like, absolutely not. And so I sent them like to Sumu or something like that, or like to the name. No, I was like, I don't know. Maybe it's like rural Kansas too, or something just.
It's intriguing stuff about like mentorship, not just.
We worked together.
Exactly. I was like, that is something that so like,
Great to meet you.
yeah, that's so true. That's so true.
Oh yeah. How are you?
Oh, sumo. I spent 5 years back.
We're just having a very quick informal chat about, are you primarily working under Sheela and Tom? Would you like to come to
Maybe.
I'm recently on NRC3 Max. It's a muscle therapy. Yeah, that's why you have familiar.
Yeah, I'm the jerk.
Something like that.
Say hi. Good to see you again. Good to see you.
No, I've been promoted. I'm full-time in background. Thanks.
Hopefully they treat you well.
I'm hoping to stick around. Good. I mean, I'm not sure if it's that. Yeah, okay, the environment.
Sheila.
Specifically sanitation,
Okay.
especially in
One.
COVID, so
Feel guilty now because I yawned walking between the rooms. I was like, oh no, that's me. She's talking about me. I'm the one that's sleeping more. Anyways. Okay, but I was intrigued because what kind of scale? Okay, you had like how many men were in the cohort? Was like 50, 20, something like that. Okay.
so we compared it before and
I was
after.
intrigued
So
because there were only 10 that reported having worked. I'm wondering where all the time is spent. So 10 reported working for an average of 2 hours. But I didn't see what is happening with the other 37 men. What are they doing? Are they just like gambling? What is happening with all their time?
Actually, that's a good question.
You know, like, it's just like,
Among those who aren't doing extensive, what are you spending your day?
Yeah.
What are the biggest proportions of time that you do it for?
They do report or
There's a lot more unpaid collective labor, so men spend more time with women on unpaid collective labor, agriculture.
oh, okay.
Repairs,
Yeah, okay.
livestock administrative
Yeah.
work, they're less watching their cows or whatever they do.
Yeah.
Sleeping.
like fairly unfairly.
But no,
So if
working with
someone could
rentals,
quantify that.
Where in Canada? I don't know the districts.
They sort of fall into
Sanbru, which is like northeast-ish.
Okay, I was trying to remember the map from a previous presentation of where rural vision interventions and stuff. Okay. So is it mostly Pennsylvania out there or? Okay, yeah, so that makes sense.
They're also like pieces of things like that. You have to go on, do you have to leave right now?
I have a list scheduled to pick it up at 4:40.
I think
Yeah.
she just
Hey, we appreciate it.
I'm glad I was able to be there.
yeah, mental
I wish I
health.
took this many here for a
No, we just love sitting here, bring us here.
Oh.
You all need.
You want to be in the front?
I don't.
Well, do you want to take one and then with the three of us?
Very active in the evening, so I need to. Email admins not tech savvy at all.
Oh, I'm sorry, I'm behind you. I'm not moving, I'm not moving.
super visible.
There you go.
Nice.
Thank you.
We'll tag you.
Box sticking out, I hope not. It's just a little blonde hair sticking out behind.
Your green shoes are fabulous. Oh, thank you. Yes, oh. Will that be in Friday? Okay, great.
So sorry, that's perfectly.
Did you do a lot of travel?
Thank you.
A lot is relative. I used to do more, but yeah, I just jumped out from Yeah, that was really to go back. I went back for the first time this January.
I wonder a little bit what it's like, because it was like, you could see the cases. I was there for like shy of 4 months.
We have
Yeah,
to
very high on the buildings.
Yeah.
I would just go to see what the professor came
Yeah, well, I moved back like after, I lived there.
Yeah.
So we event first.
Yeah, so I was in that position, for.